Hello. In this session, we shall discuss the anatomy of the tongue and oral floor, and we shall also look at some of the common clinical issues associated with the tongue and oral floor. The aims of this session are to develop an understanding of the gross anatomy of the tongue and oral floor, and by the end of this session, you should be able to discuss the structure of the tongue and oral floor, the muscle attachments related to the tongue and oral floor and their functions, the neurovascular supply of this region, and finally, you should be able to discuss some of the common clinical issues associated with the tongue and oral floor. The tongue is a freely mobile muscular organ which is attached to the floor of the pharynx. The surface of the tongue is covered by mucosa, and the core is formed by a collection of skeletal muscle and glandular structures which include serous, mucous, and seromucinous glands. In terms of the functions of the tongue, I'm sure you're familiar with most of those, which include the role of tongue in bolus formation to aid mastication and swallowing. It obviously is an organ which is concerned with taste perception and also contributes to speech, and like any other mucosal tissue, it also plays a role in the immune response of the body. The tongue contains specialized collection of lymphoid tissue known as the lingual tonsil, which contributes to the immune response of the body. So, if we look at the dorsal surface of the tongue, the overlying tongue mucosa is projected into what we call the lingual papillae. So the most numerous are the filiform papillae, which are dispersed throughout the tongue. Then you also have the fungiform papillae and the circumvallate papillae. A V-shaped groove known as sulcus terminalis demarcates the anterior 2/3 of the tongue from the posterior 1/3 of the tongue, and lining along the sulcus terminalis are the circumvallate papillae. And the lateral border of the tongue may also show a fourth type of papillae, which are known as foliate papillae. Also located in the posterior 1/3 of the tongue is the lingual tonsil, which contributes to the immune response of the body. So remember, the anterior 2/3 of the tongue and posterior 1/3 of the tongue are demarcated by a V-shaped groove, which is known as the sulcus terminalis. And the surface of the tongue, which faces the palate, is known as the dorsal surface of the tongue, whereas the surface of the tongue facing the floor of the mouth. So if we look at the histological structure of the tongue, the surface of the tongue is lined by mucosa, which is stratified squamous epithelium, just like elsewhere in the body. But where you have the presence of filiform papillae, which are the most numerous, the tongue mucosa is keratinized, whereas in the remaining areas, it is non-keratinized. So, because the filiform papillae do not contain any taste buds, their main function is to help in mastication, hence they are keratinized. Whereas where you have presence of taste buds like the fungiform papillae and the circumvallate papillae, the tongue mucosa is non-keratinized to allow the taste stimuli to reach the taste buds via transport through saliva. So that's the surface mucosa, keratinized and non-keratinized stratified squamous epithelium. Then you also have the main bulk of the tongue formed by the skeletal muscle, and that is where you also have presence of uh, the nerves and the blood vessels. And obviously, when we say oral mucosa, that includes the stratified squamous epithelium and the underlying connective tissue, which is lamina propria. So these two layers, oral epithelium is synonymous with epidermis of the skin, and lamina propria is synonymous with dermis of the skin. And then you also have the presence of duct. So the dorsal surface of the tongue is thick keratinized and non-keratinized stratified squamous epithelium. There is no distinct submucosa, and the mucosa is bound directly to the underlying musculature. The dorsal surface of the anterior two-thirds of the tongue is marked by surface projections known as papillae, of which there are three main types: filiform, which are keratinized, no taste buds; fungiform; and circumvallate. And there's the fourth one, which are more prominent in primates and rabbits, etc., less prominent in humans, which are the foliate papillae. The posterior one-third of the tongue is also known as the root of the tongue, and it extends from the sulcus terminalis to the pharyngo and glossoepiglottic folds, and it's the posterior one-third of the tongue which contains lingual tonsils on the superficial and lateral aspects. The surface of the tongue facing the oral floor is known as the ventral surface of the tongue, and it is lined by stratified squamous epithelium, which is non-keratinizing, so it's quite thin. So it constitutes the lining mucosa, just like the mucosa on the oral floor and the buccal mucosa. And if you look at the ventral aspect of the tongue, you will recognize a midline fold, which is known as the lingual frenum. And on either side of the lingual frenum, you will have the sublingual caruncles, which mark the opening of the duct of the submandibular gland, and some of the ducts of the sublingual salivary glands also join the submandibular duct. So the submandibular duct, as you know, is the Wharton's duct, and the sublingual ducts are known as the Bartholin's duct. And then you also have folds of mucosa on the side of the lingual frenum, which are known as the sublingual folds, where rest of the Bartholin's ducts they open. So this image depicts the anatomical landmarks on the ventral surface of the tongue. So starting in the midline, you've got the lingual frenum, and lateral to the lingual frenum, you've got two more vertical folds of mucosa, which are known as fimbriated folds or plica fimbriata, and these indicate the position of the lingual veins. And then you've got lateral to the lingual frenum, close to the floor of the mouth, you've got two horizontal folds, one on either side, known as the sublingual folds or plica sublingualis, and these folds overlie the openings of the Bartholin's ducts. And finally, you've got the sublingual papilla in the midline, just over the lingual frenum, and these indicate the openings of the Wharton's duct, which is the submandibular duct, one on either side. And as I said previously, some of the sublingual ducts, Bartholin's ducts, join the submandibular duct to open through the sublingual papilla near the floor of the mouth. As discussed previously, the core of the tongue is formed by skeletal muscle fibers, and these are classified as intrinsic and extrinsic groups of muscles. The intrinsic muscles, their origin and insertion is inside the tongue, and they make up most of the mass of the tongue. Their main function is to alter the shape of the tongue, but they also contribute to movement of the tongue with the extrinsic muscles. The recognized groups include the superior longitudinal muscle and the inferior longitudinal muscle fibers which run anteroposteriorly. Then you have the transverse group of muscle fibers which run horizontally, and finally you've got the vertical muscle fibers which run top to bottom. So this image provides a good view of the intrinsic muscles of the tongue and how they function. The superior and inferior longitudinal muscles, they run anteroposteriorly, and when they are going to contract, they are going to shorten the tongue anteroposteriorly. Then you've got the vertical group of muscle fibers which run top to bottom, and when they contract, they would broaden the tongue side to side. The transverse muscle fibers, they run horizontally, uh, and their contraction is going to narrow the tongue from side to side. So superior and inferior longitudinal muscles anteroposteriorly, vertical top to bottom. Now we shall look at the extrinsic muscle fibers uh, of the tongue. These originate outside the tongue, and only their terminal fibers are located inside the tongue, and their main function is to control the movement of the tongue. So there are 4 recognized groups of extrinsic tongue muscles, and their names would give you an indication about their origin and insertion. So genioglossus originates from the superior genial tubercle on the lingual aspect of the mandibular symphysis and inserts into the tongue, and the function of genioglossus is depression and protrusion of the tongue. The styloglossus originates from the styloid process to be inserted into the tongue, and its function is to pull the tongue back during swallowing. So retraction of the tongue. Hypoglossus originates from the hyoid bone to be inserted into the tongue, and its function is to pull the tongue down, or depression of the tongue, making it convex. And finally is palatoglossus, which originates from the soft palate, and it elevates the posterior tongue, closing the oropharyngeal isthmus during. So this image provides a good view of the tongue muscles. So starting anteriorly from the genial tubercle, superior genial tubercle, the genioglossus, the contraction of genioglossus is going to pull the tongue forward and also depress it. The styloglossus, from the styloid process to the tongue, it is going to retract the tongue during swallowing. Then you have the hypoglossus, which originates from the hyoid bone to be inserted into the tongue, and the function of the hypoglossus would be to depress the tongue, making it more convex. Finally, you've got the palatoglossus, which has uh, fibers contributed by another muscle which is less recognized, the pharyngoglossus, and the function of these muscles is to elevate. Now we can look at the nerve supply of the tongue. The mucosa of the anterior 2/3 of the tongue. The general sensory input is via the lingual branch of the mandibular nerve from the posterior trunk of the mandibular nerve. The gustatory fibers from the anterior 2/3 of the tongue are carried via the coda tympani branch of the facial nerve. So for the anterior 2/3, lingual branch of the mandibular nerve is general sensory, whereas coda tympani branch of the facial is special sensory or gustatory. However, the taste fibers from the circumvallate papillae, which line the sulcus terminalis and mark the junction between the anterior 2/3 and the posterior 1/3 of the tongue, these are supplied by the lingual branch of the glossopharyngeal. which also provides general sensory innervation to the posterior one-third of the tongue, as well as gustatory sensation or special sensory fibers to the posterior one-third of the tongue. So the lingual branch of the glossopharyngeal, which is the ninth cranial nerve, provides general sensory as well as special sensory fibers to the posterior one-third of the tongue, including the circumvallate papillae. I think I might have misnarrated it in the presentation on the mandibular nerve, so that should be clear. And then finally, the most posterior part of the tongue may have contributions from the superior laryngeal branch of the vagus nerve, both general sensory and special sensory. And we'll come to it in a bit more detail in the next slide. In terms of the motor nerve supply, all muscles of the tongue, intrinsic and extrinsic, are supplied by the 12th cranial nerve, which is known as the hypoglossal nerve, with the exception of palatoglossus. Palatoglossus is supplied by a combination of fibers from the 9th, 10th and 11th cranial nerve, and these fibers together form what we call the pharyngeal plexus of nerves, and these provide innervation to the palatoglossus muscle. So that's a common. So I've shown you this image in my presentation on the mandibular nerve as well. This is quite a useful image which shows the medial aspect of the mandible, including the body and the ramus, and you can see a variety of structures. So you can see the mylohyoid muscle, which is attached to the mylohyoid ridge and forms the floor of the mouth side to side, and it is supplied by nerve to mylohyoid, which branches off from the inferior alveolar branch of the mandibular nerve before it enters the mandibular foramen. And this nerve to mylohyoid is also going to supply the anterior belly of the digastric. So I'm trying to prepare you for all your MCQs. You can also see the geniohyoid muscle from the inferior genial tubercle running in the midline towards the hyoid bone. This is the hyoid bone. And obviously superior to this, you can see the superior genial tubercle, which is going to attach the genioglossus muscle. So superior genial tubercle, genioglossus, inferior genial tubercle, geniohyoid. You can also see the submandibular salivary gland, the sublingual salivary gland. So the submandibular salivary gland is inferior to the mylohyoid muscle, whereas the sublingual salivary gland is located superior to the geniohyoid muscle, and only the oral mucosa, the overlying oral mucosa, separates it from the oral floor. You can also see the inferior alveolar nerve and vessel, artery, entering the mandibular foramen. You can also see a branch of the inferior alveolar nerve coming off, which is the nerve to mylohyoid, which we've discussed. You can see the lingual nerve and the coda tympani nerve. And beware of uh, all these structures, because you will need to know this anatomy when you learn when you undergo your training on. So now we can look at the gustatory input to the tongue. So as you know, the taste buds are mainly located in the fungiform papillae in the anterior two-thirds of the tongue, the circumvallate papillae at the junction of anterior and posterior one-third of the tongue, and then you also have taste buds located on the epiglottis, the pharynx and the esophagus. The gustatory innervation to the anterior two-thirds of the tongue, which is mainly for the fungiform papillae, the taste buds located in the fungiform papillae, is via the coda tympani branch of the facial, whereas the general sensory supply, we said, is via the lingual branch of the mandibular nerve. The taste buds in the circumvallate papillae are innervated by the lingual branch of the glossopharyngeal nerve, which also provides general sensory input to the posterior one-third of the tongue. The taste buds in the pharynx as well as esophagus and on the epiglottis are innervated by the superior laryngeal branch of the vagus. Now remember, the presence of taste buds in the epiglottis, pharynx and esophagus is primarily for protection of the airway, not for taste perception per se. And taste fibers from all these locations, fungiform circumvallate papillae, pharynx, esophagus and epiglottis, they are projected to the nucleus tractus solitarius in the medulla oblongata, which is the taste nucleus, and from there the fibers are projected to the thalamus and finally to the gustatory cortex. So this image provides you with a good opportunity to revise your anatomy of the ventral aspect of the tongue. So you can test yourself as we go along. So one is the midline soft tissue fold, which is the, yes, lingual frenum, that's the easiest. Then you also have these vertical folds on the side of the lingual frenum on either side. These are fimbriated folds which overlie the position of the lingual veins. Then you have these horizontal folds which are known as the sublingual folds and overlie the Bartholin ducts from the submandibular salivary glands. Now 4 is the papilla, which is indicating the position of the opening of the Wharton's ducts. So the caruncle or papilla, submandibular caruncle, and 5 indicates the actual opening of the. Next we can look at the arterial supply to the tongue, which mainly comes from the lingual artery, which is a branch of the external carotid artery. And the lingual artery not only supplies the tongue but also supplies the sublingual salivary gland, the soft tissues of the oral floor and the lingual aspect of the mandible. So the lingual artery has several branches. The dorsal lingual to the dorsum of the tongue, the sublingual to the sublingual salivary gland, and also it has suprahyoid and deep lingual branches which provide arterial supply. Finally, we can look at the lymphatic drainage of the tongue. The lymph from the tip of the tongue drains to the submental group of lymph nodes, which ultimately drain into the deep cervical group of lymph nodes. The rest of the anterior trunk as well as the posterior trunk, they all drain into the deep cervical group of lymph nodes. The important thing to remember is that the lymphatics provide a pathway for spread of cancer, which is known as metastasis. So, as you know, tongue is one of the commonest site of intraoral cancer, and squamous cell carcinoma can spread from the tongue into the lymph nodes, which significantly worsens the prognosis of survival for oral cancer. And it's important to recognize that some of these vessels, they cross the midline. So if there is a cancerous lesion on the right side of the tongue, there is a possibility that it can spread to lymph nodes on the opposite side because the lymph vessels of the tongue, they cross the midline. So this is so now we can look at some of the common clinical conditions associated with the tongue. So this slide depicts an enlarged tongue, which is known as macroglossia, and you can clearly see crenations on the lateral borders of the tongue because of the increased mass. The tongue fits against the alveolar arch, and the close abutment against the teeth creates these crenations. And macroglossia could be associated with a wide variety of conditions. So I'll just give you a few examples. One is acromegaly, hyperpituitarism in adults. Then you can also have macroglossia associated with uh, certain forms of hypothyroidism like myxedema. This slide depicts another interesting condition, which is enlarged circumvallate papillae. As you know, normally 8 to 12 circumvallate papillae line the sulcus terminalis, and usually they are not that prominent, but sometimes as a result of irritation from hot food, allergies, etc., these papillae can get enlarged and can, depending on uh, how quickly this develops, they can lead to considerable discomfort for the patient because they would feel as if something is stuck in the back of their throat. But what is important is to allay fears of cancer phobia. This is a benign condition and it's important to recognize it, and many a times it. Another common condition associated with the tongue is the lingual varicosities, which are basically enlarged prominent sublingual veins, which is mainly seen in the elderly population. So again, as tongue is a common site for oral cancer, people often worry about it. So just to reassure them that it's just, something which develops as part of aging. So they are very similar to varicose veins elsewhere in the body and don't generally require. This is quite a remarkable condition known as hairy tongue. So basically, as a result of irritation from smoking, poor oral hygiene, certain medications, particularly antibiotics, the filiform papillae may hypertrophy and create stagnation areas where bacterial activity related to chromogenic bacteria can cause yellow to brown to black staining of the tongue dorsum, hence the term hairy tongue. So generally it starts off as a yellow hairy tongue, then becomes darker in color as time progresses, and if the uh, precipitating factors they persist, such as smoking, again, because of the remarkable nature of the uh, hairy tongue clinically, it's important to explain to the patient that this is a benign condition. Obviously, if they are smoking is a risk factor for cancer, oral cancer, but this condition as such is not cancer. So it only relates to hypertrophy of the filiform papillae, and management centers around smoking cessation, good oral hygiene, and usually brushing the tongue, and usually this condition can resolve. Sometimes the tongue dorsum may display very deep fissures, and we call this condition as fissure tongue. And generally it doesn't indicate any disease or anything, it's just a variation, but may warrant uh, meticulous oral hygiene to prevent stagnation of food. Another common condition related to the tongue is tongue tie or ankyloglossia, which is basically due to a short lingual frenum, which tends to impair the movement of the tongue and may interfere with speech development. This is something which can be identified at the time of birth, and if there is any functional impairment or interference with speech. Another common condition which can involve the tongue is herpes simplex virus infection, which can cause multiple ulcers on the tongue, particularly in children. So herpes simplex virus infection can involve the tongue, leading to ulcerations. Similarly, aphthous ulcers which you will learn more about uh, in the latter stages of the program, can also involve the. This image shows atrophy of the tongue on the left side, and this is related to damage to the hypoglossal nerve. So hypoglossal nerve, as you know, is the main nerve supplying the muscles of the tongue, and if the hypoglossal nerve is damaged, either due to a central lesion in the brain like a stroke or a tumor or trauma, or as a result of peripheral damage following a surgical procedure or trauma, the tongue muscles, because they will not receive uh, neural input, they are going to atrophy, which will translate into atrophy of the tongue, because the bulk of the tongue muscles is bulk of the tongue mass is. Finally, you would be aware that the tongue is the commonest site for intraoral cancer, and the most favored site of intraoral cancer on the tongue is the lateral border of the tongue. So you can see a large mass on the lateral border of the tongue on this image, which appears to be ulcerated, has white areas. So this is how classically oral squamous cell carcinoma, which is the commonest type of oral cancer, constitutes for over 90% of oral cancers. This is going to present clinically. So uh, part of your soft tissue examination should also always be focused on identifying red or white lesions on the oral mucosa, particularly the tongue, any ulcerated lesions or any mass lesions, because these four constitute the main presentations of oral cancer, that is either a white or a red patch, a non-healing ulcer, or a mass which develops. For further reading, you can consult these texts, which includes Netter's Head and Neck Anatomy and my book on physiology for dental students. You would find useful information in these